So welcome everybody. My name is Dr. Hatem Soliman.
I'm Dr. Alvaro Moreno, one of the other co-chairs of this meeting, and thank you very much for joining us on this beautiful Saturday afternoon.
Yeah, absolutely. We're very happy to take everybody's questions, and we hope that everybody found the information informative and useful. So without further ado, we'll dive right into the questions and get that going. So the first question I've seen here on the chat is looking for advice in those with triple negative breast cancer who receive neoadjuvant therapy, but then have residual disease after treatment. How to decide between capecitabine, olaparib, and pembrolizumab? Sequential, in combination, one preferentially? This is a great question. Obviously, it's one that we don't necessarily have a lot of data around necessarily how to pick between the various treatments because one of the issues, and Alvaro, you're familiar with this too, is that none of the trials really allowed the use per se of the other agents pretty much like as part of the routine study treatment. So CREATE-X, which led to the use of capecitabine in the residual setting, was done well before either of these agents like olaparib or pembro were around. Keynote 522 didn't really routinely use adjuvant Xeloda either. And the Olympia trial recently also did not. And so, I think at least from the standpoint of if I knew somebody was a BRCA mutated germline patient, based on the recent data, I think the data from Olympia looks pretty impressive. And I would probably prioritize the olaparib in that setting. And in patients who were candidates for pembrolizumab and had started it as part of their neoadjuvant therapy, and if they had residual disease, that is something that, again, we're not sure regarding the continuation of the pembrolizumab in the adjuvant setting versus sequencing over to capecitabine. My sense would be in general that I likely would consider, if they had significant residual disease after the initial therapy with the pembrolizumab, I would give a consideration for capecitabine. And then obviously if they were not a candidate for either drug, adjuvant capecitabine is what a lot of us are doing. Alvaro, do you have any thoughts on that?
Yeah, so most patients will be eligible for capecitabine, number one, and I think the comparison of the cisplatin capecitabine shows that capecitabine is good as, so we'll do that. For pembro, we have used in some patients with our very high risk young patients. We obtained the drug through compassionate use from the company, and they're being very good at it. We're still waiting for FDA approval for such indication. I know my colleagues with the melanoma group think that checkpoint inhibitors are just given like normal saline and have no side effects, but I do respect that drug. We have had some patients with hypothyroidism and other autoimmune conditions, and sometimes it worries me when providing right before surgery in the neoadjuvant setting, because we have a time frame that we just don't want to delay that surgery. So we kind of get some concerns getting one of those side effects. For the olaparib, we expect this will be approved later this year. The ASCO guidelines that came last month were very stringent, meaning that they will follow exactly like the trial was conducted. So are truly high risk, hormone receptor positive in some of the triple negative breast cancer. The big question we're having now is how far from surgery which we consider giving olaparib when that comes. In the study, ideally, they wanted to do it within 8 weeks of finishing all the adjuvant therapy, whether that would be chemo, radiation, or so forth. And it was a maximum of 12 weeks.
12 weeks.
So that discussion now is going on. If it gets approved, a lot of our high-risk patients would like to take it. And the question is, how much time frame will we allow, and insurance might define that for us, or the FDA on their approval. We'll have to see. For a lot of the patients who don't qualify for olaparib or have finished their capecitabine, we do have a vaccine trial, a folate receptor vaccine trial. There is, we initiate that about 90 days after the last treatment, whether that will be capecitabine, radiation therapy, or so forth. And we have up to 500 and something days from the original diagnosis, so it gives ample time. So if you guys would have a patient interested in participating on the trial, it's a randomized phase 2. 2/3 of the patients get the real vaccine, 1/3 get a placebo vaccine. It's monthly for 6 months, and then once every 6 months for 3 years. So please reach it to us. Yeah.
Yeah, so then it's a good discussion. I mean, obviously there's still limited data and it's evolving, but I think, yeah, the bottom line is most patients would get capecitabine currently, but in those that, are germline BRCA, probably in the near term, adjuvant olaparib, like if you're starting them on treatment, would probably be the consideration for those patients. And for Pembro, again, we're hopeful that, yeah, as far as using this agent, we'll have to see whether continuation of it in patients with significant residual disease would improve outcomes. So we'll have to keep an eye on that. And so next question, how does the use of a PARP inhibitor in the adjuvant space impact treatment of breast cancer in the metastatic space? What would be the sequencing strategy? Well, this isn't just limited, I think it's a great question, to PARP inhibitors. I think we're dealing with this across the board, even in HER2 positive disease with Catherine and the use of TDM1, for residual diseases. As more agents move up in the curative setting, and those patients, kind of have been exposed to those drugs, there's always a chance that depending on the timing of when a relapse occurs, in particular how long it was from their last exposure, that you would suspect they're resistant to that last treatment. And so somebody who got adjuvant PARP, for example, and promptly had a metastatic relapse, it's quite likely that they're already resistant and have activated alternative DNA repair pathways, that would likely alter your choice of agents, in the metastatic setting. And in that case, you are likely going to be probably not doing PARP inhibitor again if they had a very short DFI, and likely going to something like chemo, or if they're PD-L1 positive, for example, triple negative disease, you could consider doing Tizo and Abraxane, for example, if they were PD-L1 positive, or like say something along like Pembro, based on the Keynote 355 data, if they're positive for 22C3, once that gets through. So I think, the sequencing would be altered if you thought they were resistant. If they had a long DFI, went years from their last exposure, that could be a different issue, where there is a lot of data that suggests that patients who go a long time since their last exposure from a DNA damage repair inhibitor like a PARP, they actually may in some cases get resensitized or regain some sensitivity, in which case you may consider recycling it. But I think it really depends on the individual case. Would you agree with that, Alvaro?
Yes, absolutely. One thing I've been doing just in the last year on some of these patients is to use an induction-like chemotherapy for 6 months, get the best response, and then switch them to a maintenance PARP inhibitor on these patients, following a little bit of what our gynecology oncology colleagues are doing, trying to keep them into the best response as long as possible.
So I think that was a good question, and obviously one that we're going to be dealing with more and more as more agents kind of shift around, in the early setting. And so let's see. Next question is for triple negative breast cancer patients that are BRCA mutated, residual disease, post-neoadjuvant. And this is, I think, a similar question here that popped up with, but it's asking, would you treat with olaparib and capecitabine or olaparib alone? And in general, I would say, really, we don't have data regarding the efficacy of the combo. And I would not do that off study or just routinely giving both agents together. I don't think that the data would support that. So, I mean, if we're looking at a clinical trial, that's a different matter, but not off of a clinical study. I would not do the combination concurrently.
But I don't think it would be wrong if you have someone with a very high risk to sequentially do your adjuvant capecitabine and then consider the olaparib afterwards.
Yeah, I think, that's one of the concerns, like you pointed out, the timing of when you stop like all of the local therapy and when they enrolled people on there, it's hard to know, like, if you were going to do 6 to 8 cycles of capecitabine in the adjuvant setting, that could take you well out of that window for that sequence. And it can be a challenge, I think, to be able to sequence patients that long for both agents. But yeah, it's one of those things that we don't have a lot of data on to say that they have additive or synergistic effects when you do one versus the other, so that is something that is still to be determined, I think, but frankly, I think the prioritization right now is likely, if you do suspect that they're germline BRCA, that you've tested them ahead of time and they are BRCA mutated, the data still is basically saying, well, you could do olaparib in the adjuvant setting to start it within the window and not necessarily do a combination. So yeah, and I think, Alvaro, have you seen, because this is all very new, data. So, the idea is like in terms of patients that are coming through your clinic right now that have residual disease and they're in varying stages of treatment, what kind of discussions are you having with them?
Hatem, I'm going to pass for a few seconds if you want to go on the next question. I have a spam phone call, looks like.
Oh, sorry. Okay. Well, we'll get back to that. So then the next question is, somebody's asking about looking for input on a young patient, triple negative, it looks like breast cancer that's inflammatory. And they only received dose-dense AC prior to having the mastectomy because they had complications, including endocarditis. And it looks like here, in this case, the patient achieved a pathologic complete response on pathology. Would you be more inclined to try to get adjuvant taxane in? This patient seems to have everything go wrong. So it sounds like patients not tolerating chemotherapy well, and but appears to have had a really good response to dose-dense AC. But unfortunately, too, it looks like the patient's a high-risk case. If they truly had inflammatory breast cancer, that makes them a very, very high-risk patient, and they're young with triple negative disease. So I think this is a pretty significant dilemma. On one hand, there is data to suggest that patients who attain a PCR from whatever neoadjuvant therapy they receive are likely to do well. That data does exist. And so one could argue that, well, the dose-dense AC worked so well that they're not likely to benefit from more adjuvant therapy in that setting. I will say, though, that all the historic data around where the advantage of adding taxane to anthracycline therapy, in particular ER negative disease, node positive or high risk disease like this, taxane added to AC in many cases, is what has been shown to improve long-term outcomes and cure rates. And one of the challenges with inflammatory breast cancer is because of the extensive infiltration within the dermal lymphatics in the chest wall, post modified radical mastectomy, there is a pretty significant chance of disseminated disease, in this patient. So, I think if you're going to be very conservative, I know many would consider trying to finish out all the chemotherapy that they were destined to give by giving the taxane adjuvant. But if she had a very poor tolerance, or she just got very ill and had a lot of complications from chemotherapy, and she had a path CR, I think in some cases, there are some providers that would not continue, particularly if the patient was reluctant or resistant to get it. But what's your thoughts on this?
Yeah, I agree. If it was other situation, I think, and the patient had had so many problems, I would feel comfortable stopping at that point. Let's say it was an ER positive tumor and put them on the endocrine therapy. A inflammatory triple negative would have such a high risk of relapse that I would sit down with the patient and have an honest discussion on trying to do the adjuvant taxane, even considering with a little bit of carboplatin in that. I also would discuss with the patient that a weekly paclitaxel is a lot better tolerated than the AC. And I always discuss with the patient, we can always stop if they were to have problems with that. And then she were to say, I try and I couldn't go farther, then I'm fine. We did our best, but I will have a good conversation with the patient trying to at least proceed with the adjuvant taxane in this situation.
Yeah, I think it's a very difficult situation overall because of that. Like, they did well with chemo in terms of the response, but they didn't do well with tolerability. But I think the extreme risk posed by the case, I think many would be nervous to not have given both the anthracycline and the taxane. And I agree with Alvaro, weekly Taxol generally won't usually cause the same level of toxicity. And it is one of those things that if you tried it and the patient wasn't tolerating after a few cycles, then at least you feel like you did your all, you gave it your best, shot. And so, yeah, I think but that's a good question. Okay, so Alvaro, do you see the next question up? Do you want to take that?
Hatem, my last question I have looks like it was from some of the copies of that they lean forward. So I'll let you get the question. I'll be glad to answer it.
Okay. Yeah, I'm just saying that I guess there was a question previously about PE and ribociclib. You'd already addressed that question, I think, previously?
Yes, we discussed it. And so in that situation, my understanding is the PE occurred sometime way before the diagnosis of a metastatic breast cancer. So I will not, just because of using a CDK4/6 inhibitor, place a patient on oral anticoagulation. I'll likely put the patient on a little baby aspirin for prophylaxis. On the other hand, if the VTE occur while the patient has active metastatic disease, then the metastatic disease is what is causing the hypercoagulability, and that patient should consider indefinite anticoagulation in that situation.
Yeah, no, that sounds very reasonable. I agree with that. And then I think there was another question maybe asking about hormone receptor positive, HER2 negative metastatic patient had MDS and pancytopenia. I don't know if that was, did you feel that question too? Looks like a situation where patients pancytopenia chronically from prior MDS treatment.
Yeah, so unfortunately, that's not that rare to happen to us. If one is the use of endocrine therapy alone. Second, in this situation, I have used abemaciclib among the three CDK4/6 inhibitors. Cause a little bit less cytopenias, more diarrhea, but less cytopenia. I've used capecitabine, dose adjusted. So the patients still have options, even with the underlying MDS for the treatment of their metastatic disease.
Yeah, I agree with that. So yeah, and I think even one of the reassuring things is the efficacy of the CDK4/6s even at the lower dose levels, where you don't get that same degree of myelosuppression, still pretty good, So I think it does allow you to maintain them at reasonable counts, maybe even with moderate or mild neutropenia that they're asymptomatic, for example, and you don't have to interrupt their treatment cycles very often for that reason. So I agree with that.
And I usually will start them on the middle dose and go up and down, depends on tolerability from there. So
yeah, and we've done that. We've done that from time to time too, just to see what we can get away with in terms of dose intensity. All right, very good. So next question here is triple negative breast cancer receiving carbotaxane for 6 cycles and has residual disease. Do you give anthracycline routinely then? At least usually the discussions in our tumor board is typically yes. If a patient got a carbotaxane doublet and they had significant residual disease like RCB2 or 3, and for some reason they didn't get the AC neoadjuvant, most of the time they will be recommended to get that. Keep in mind CREATE-X, for example, that data was generated in patients that had seen both the taxane and anthracycline with residual disease, not in those who just gotten, like, say, taxane alone or non-anthracycline treatment. So I know at our tumor board, usually we would offer them the anthracycline unless they had a medical contraindication to getting it in the first place. So I know, is that similar to what you guys do, Alvaro?
yes, I mean, I'm not confronted with this situation that often because most of the time we will give the anthracycline, and the reason when we would not give the anthracycline in the regimen in the neoadjuvant setting for triple negative will be a contraindication of previous exposure to anthracycline, in which is the time that usually we will discuss maybe 6 cycles of docetaxel carboplatin in that situation as the preferred regimen. So yeah.
Yeah, I think where people get into trouble with this is they're trying to kind of de-escalate the treatment in a creative way. And sometimes they get a great response radiologically or on exam. So they think they're good to go. And then they get surprised on final path and they get left with the situation, which is why we generally tend to give both agents up front, because it's hard right now to be able to accurately fully assess PCR, reliably that way. So to avoid that scenario, we often will give both, but that's a good question. How will you treat? Oh, go ahead, Alvaro. Were you gonna say something?
No, I was just said I can see the questions now, so I can take the next one.
Okay, yeah, the next one here.
Yeah, how will you treat triple negative who relapse with brain metastasis? I assume solitary brain metastasis status post resection. So this is a situation that happens not only with the triple negative, but the HER2 population in which they don't have any other area of systemic disease and has a single relapse in the brain. And we resect it. We treat it with post-operative radiation therapy. You have 2 approaches, and one is to sit down with the patient and say, well, there's no evidence of, you'll do the systemic evaluation, make sure there's no disease elsewhere, but have the conversation that there's no target lesions. And so at this point, we can just observe and wait for evidence of objective relapse elsewhere in order to initiate therapy. We have had some cases in which we have discussed in the triple negative use of capecitabine because they have CNS penetration. The only problem is I upfront tell them there's no endpoint, so we need to discuss, if 6 months or a year goes by and there's no evidence of emergence of disease, we may need to discontinue the therapy. I had a similar patient right now, HER2 positive disease, and the patient was very uncomfortable not doing anything, and right now she's on the capecitabine tucatinib Herceptin therapy. It was a large brain metastasis that was fully resected, and we're on the 4 or 5 months so far with no evidence of recurrence of disease. And I went along with her trying to treat in this situation, but we may have a different conversation when we reach the 1-year mark.
Yeah, it's a tricky situation. I think there's no data, and you could either talk about observation versus doing systemic treatment. I think also there's been some interesting data looking at other blood-based biomarkers like ctDNA in some cases as well, and tumor markers, just seeing if there looks like there's evidence of still disease that is not visible on PET CT, for example. But in some cases, you may get treatment You know, in those cases, you know, where you suspect there's lab abnormalities like elevated tumor markers or ctDNA that's positive. But yeah, we've seen some data along those lines too, but it's definitely a conversation you have to have with the patient. So the next one, Alvaro, they're talking about the ER positive BRCA. Do you see that one? Yeah, do you want to
Yeah, ER
take that one?
positive, BRCA positive. The study with olaparib required 4 lymph node. Would you adhere to these or liberalize to any nodes? It's a very good question. But as I mentioned earlier, I think insurance and the FDA may define exactly how we can prescribe this medication. The June guidelines by ASCO follow exactly what the protocol had required. So we're waiting to see. This is an ongoing conversation we have among colleagues at all 3 Mayo sites at this point. And so we're waiting to see what the FDA indication is going to be. These are expensive medication, and it may come back that once we prescribe, they may come back and say that this patient, if he had 1 positive lymph nodes, will not qualify and the insurance will refuse.
Yeah, I agree. But I think, yeah, it's to your point, it's going to be driven a lot by the label and indication reimbursement. But for the most part, yeah, they're looking at the clinical trial eligibility criteria that were used to risk stratify the patients. And then I think you can address this last one too, Alvaro. I think it's talking about Latin America as well, countries and CDK4/6 treatments. I'm not sure if that's the gist of it, but
yeah.
can you see that question?
Yes, that the CDK4/6 are expensive, and I agree. They're $12,000 a month and impossible for many patients elsewhere to afford. I mean, and even in this country, if patients will have to pay out of pocket for these medications, they will not be able to afford them. I don't have a good answer for you. I mean, there a lot of these trials are now international trials, and many of the cooperative groups from Latin America do participate, from Peru, Brazil, Argentina, and so forth. So I agree. We should continue expanding centers across internationally across the world to participate in these clinical trials.
Yeah, no, I agree. I think it's incumbent on everybody to try to have a broad inclusion globally to try to make sure that people can benefit from these treatments, you know, in the broadest sense possible. So I think that is work that needs to be done, and I agree with that. Well, I think we're out of time, Alvaro, for the Q&A session. So, you know, I'd like to thank Alvaro for a great discussion and session. It was a pleasure to be on with you. And thank you for everybody's participation and excellent questions as well. We now have a time to take a quick break. So I'd encourage everybody to try to you know, take some time to explore and chat with the exhibitors in the exhibitor session, and also thank them for helping to make the meeting happen and their support. And there's also a CME presentation on optimizing therapy in HER2 positive disease that's available to view in the on-demand session as well. And you can look at that on your own time. So I encourage you to do that. And we really thank you for participation and hope everybody has a great weekend. Take care, everybody.
Thank you, everyone. And if you have any questions additionally, please feel free to send us a message or email.